This ligament, when attached, prevents the knee from going front and back. This movement, it's prevented. We lost the meniscus there. Hi, I'm Omar Perez, orthopedic surgeon, specialist in sports medicine. And today we're gonna talk about Kyler Murray's injury that put him out of the season. He was playing and got a non-contact injury to his knee. His knee gave out, he landed on the floor, he couldn't return to play, and he was escorted outside of the field. Later, he received an MRI and was confirmed that he suffered an ACL injury. An ACL injury is perhaps one of the most common knee injuries in football players. It's an injury that not necessarily requires a trauma. It's what we call a non-contact injury, meaning the player is trying to accelerate and decelerate or doing some sort of pivoting movement. And while his foot is planted on the ground, the knee shifts, and that shift along the knee causes the ligament to rupture. So this is a knee model for explaining what the ACL is. So this is the front part of the knee. We have the femur and the tibia, and this is the patella. So if we remove the kneecap and we see within, we have both meniscus in between the two bones, and then the ACL is this ligament that lays right here. It connects the femur with the tibia, okay? If you look at it from the side, this ligament, when attached, prevents the knee from going front and back. This movement, it's prevented. We lost the meniscus there for a while, but
here's Kyler Murray's meniscus. There you go.
There's the meniscus. So these movements prevent the ligament prevents the tibia from going front. Now, in that deceleration movement, the tibia translates anteriorly, and this is how the tear happens. Goes back, and the knee automatically comes back into place. So it's something in a matter of microseconds. The player usually feels a snap or a pop. Some of them are able to put a little bit of weight, but it's very uncomfortable, and then within a few hours the knee start getting swollen. Sometimes the ACL injury doesn't come on its own. The most common injury with an ACL, it's a meniscal tear, which is also very common to see. The most common meniscus torn is the lateral meniscus. The meniscus is the shock absorber of the knee joint. When lays on top of it, it provides some sense of stability to the knee.
Is the lateral one the outside or the inside?
The lateral one is the outside part of the knee. Okay? In the knee, we have two ligaments. We have the ACL, and then we have the PCL, which is the counterpart of the ACL. It's less commonly torn, but also can suffer an injury. I'll put this back together here with my friend's knee.
Is this what surgery's like when you're?
It's identical. It's like I'm operating. The ACL confers stability to the knee. It also allows the patient to have some sense of balance with respect of where the foot is planted on the floor. ACL injury, it's a season-ending injury, requires surgery, and the average return to sports, it's about roughly 9 months. It has been shown that any patient after an ACL reconstruction that comes back earlier, the chances of re-injury increases. So in my practice, the standard of care is releasing the patients after 9 months, so long that they have completed a standard return to sport testing. How do we fix an ACL? So the ACL, because it's inside the knee joint, the fluid that bathes the knee joint has certain components that doesn't allow the ACL to heal well. So even in the setting that we try to mend that ACL back together, the chances of healing are very poor because the ligament doesn't have good blood supply, which is the main factor for healing. And also the bathing of that fluid interferes with the healing process. So how do we fix it? If we cannot repair it, technically, then we need to reconstruct it. The way we rebuild a new ACL in athletes is taking their own tissue and transforming it into a ligament. The tissue that it's considered the gold standard, it's taking a plug of his tibia. We do a cut here where this bony prominence is located. Then we take a strip of about a centimeter of the patellar tendon, and then we also take a bone plug of the patella. That leaves us with a configuration of bone, tendon, bone. That graft, which is how we call it, has the lowest re-tear rate in athletes and young patients, and provides better integration to its own body because the two bone plugs heal very well. Once we extract the graft, then I do it arthroscopically assisted, in which I do a hole in the skin here, another hole here where I insert a camera. That's called arthroscopy. And through those two holes is where I do most of the work. Then once you have everything prepared, in order to pass the graft, okay, you do a small incision here in the skin, and then you have to drill a hole with something that we call a large drill bit. We drill a hole called a tunnel, and that tunnel goes from outside of the bone and comes out through inside part of the bone. Typically comes out through this area where the attachment of the ACL is. And once we drill that, we shuttle that graft inside the knee joint. Once the graft is inside the knee joint, we've also drilled a hole on this part, and the docking part of the graft is inserting one bone plug here and the other bone plug inserts there, and then you fix it with either sutures, you can use screws, you can do a lot of devices to temporarily fix that graft in place and allowing it to heal. Once the graft heals, then the metal is just, it doesn't serve any purpose anymore. But we don't go in there and take it out. It lives with the patients forever.
Would you say you kind of make an ACL outside of the body and then put it in, like drill it inside of where it would have been?
Correct. This graft that we take, our assistant, while I'm doing the rest of the work, I take it to the back table in the OR. I have a first assist that she's trained in how to prepare the graft, and she contours that graft and reshapes it into what it will be a new ACL ligament. Remember, we're turning a tendon, which is the patellar tendon, into a ligament. So that transformation of tendon to ligament, which is called ligamentization, can take 6 to 9 months. That's why time-wise, we need to allow 9 months for the patient to return. If it returns too early, that process hasn't completed, so the chances of re-injuring it are higher. In the setting that the patient has also a tear of the meniscus, we can repair through the same approach, but by putting a couple of sutures to mend the meniscus back together. And then after the surgery, the rest of our recovery occurs in the physical therapy room. It's very aggressive rehab to first improve your range of motion. At around the 3-month mark, most patients are running on a treadmill. Some surgeons use a brace for the first 2 months to, protect the surgery. Then comes the strength and conditioning phase that takes at around the 3 and 6 month mark. And then around the 6-month mark, you put the patient through a return to sport testing, which is more sport-specific drills, agility exercises, and the testing entails taking basically an exam for your knee. That gives us specific metrics and numbers that tells us whether the patient is ready to return or if there are still some deficiencies that we need to work on. Some surgeons will give the patients what we call a functional ACL brace, which is a specific brace to be used for returning to sports. That brace hasn't been proven to prevent any re-injury, but what it does, it gives the athlete the confidence to get back into sports, because not only an ACL recovery entails a lot of physical demand for the rehab, but it's mostly psychological. Most of these patients are worried, they don't trust their knee. Am I gonna be able to go to the pre-injury level? So in that sense, a brace specific for that gives patients the confidence so they can progressively get into full sporting activities. And then once the patient is released, then hopefully the risk of re-injuring that knee kind of equilibrates with the non-injured knee. That's pretty much ACL injury and reconstruction in a nutshell. It's expected in the football environment. They pretty much get surgery within the same weeks because time is money, you know. Different from a normal orthopedic clinic where, you know, patients can wait and do the surgery a few weeks later. Every moment that player is not in the field it's money that costs to the organization. So they want to do the surgery right away and try to rehab as soon as possible. So Kyle Murray, it's probably looking at around 9-10 months before he can return to play. So that would be, you know, way around the beginning or middle of the season of 2023.
They just paid him a lot of money too. I'm pretty sure he just got a ginormous contract.
Usually, yeah, we see that a lot. It's like the curse of the highest paid. You get a big contract, and either you don't perform well for whatever reason, you get comfortable, you don't train, or injuries happen. This is not something that he could have prevented. This is just the way of an athlete, and they know what they're getting into. Football players know that playing football, you know, you're gonna get concussions, you're gonna get shoulder injuries, and you're gonna get knee injuries. Now, are the benefits overweigh the risks? I think so, because, you know, it's good money that they get paid. So hopefully he comes back to the field.
Bueno, sí.